Hello, everyone. All right. I'll try to pay attention. I'm sure we'll still have some folks continuing to join us in the waiting room. Here in the middle. But I will go ahead and get us started so we don't take any time away from Dr. Work. So good afternoon. Thank you for joining us today for the Long-Term Care Antimicrobial Stewardship webinar series. I'm Loretta Fitzgerald with KFMC Health Improvement Partners, and I'm really excited to kick off the series again today. This is our third session of the 5-part series. And today's is focused antibiotic stewardship initiatives for upper and lower respiratory infections and immunizations. So before I get started, I do need to remind you that if you're seeking CNEs, make sure that you remain on for the entirety of the presentation, and please complete that program evaluation form. The program evaluation form should pop up at the end of the webinar. Certificates of attendance and CNE will be sent out via email. We are recording the presentations, and this one should be available on our website soon. And I know that the first 2 of the series have already been posted. We encourage you to share these recordings with your colleagues. However, do note that the CNEs are not available with the recordings. If you have any questions, please feel free to reach out to me at any time. And to introduce our presenter, Dr. Kelly Wark. She's an assistant professor of infectious disease at the University of Kansas Medical Center, as well as the subject matter expert of antibiotic stewardship, healthcare associated infections, and antimicrobial resistance in the KDHE's HAIAR section. And at KDHE, she's the antimicrobial stewardship co-lead. And at KU, she serves on the antibiotic stewardship program and is the co-chair of the vaccine and ambulatory subcommittee task force groups. So please welcome Dr. Wark. And then I will get our slides shared here in just a second.
Thanks, Loretta.
Are you seeing the?
Yep, looks good.
Okay.
Okay, next slide. Next slide. So as Loretta mentioned, third in our series of kind of syndrome specific stewardship initiatives, and kind of if any of you also have been tuning into the KHC series, kind of in that similar to that, but with some additional information on immunizations, and plus at the very end I was going to talk about some of the new RSV vaccines too, which was recently approved for those over 60, as well as like pneumococcal vaccinations. But today was really going to talk about some of the epidemiology around upper respiratory infections, pneumonias, how to develop some facility specific guidelines, and then there's some background on the line. Let's see. And then describe finally some communication strategies to how to improve kind of our antibiotic prescribing for these. And at the very latter half of it, we'll talk about some of the vaccines. Next slide, please. Okay, so some terminology here. So we all know what the flu is, and mostly, and even sometimes that gets confused with like people think that like a gastroenteritis is more flu, but really flu is really when we're having fevers, muscle ache, chills, you know, versus the GI bug is really more other viruses like norovirus and stuff. So stomach flu is not flu. But what we think of the common cold is really kind of in this vicinity. So it's really in our upper respiratory, you know, it's on our nasal, we get congested, we have maybe a little bit of sore throat, scratchiness. So we're having more sinus and kind of upper here. You get into bronchitis, gets a little bit more into your bronchial tree. This is where you have like the prominent cough more so. Most of these, all, you know, both common cold and bronchitis are viruses, but these really can persist for a while. You know, you can really get some irritation and have a cough persistent for a while. Finally, pneumonia. So we think of pneumonia being bacterial, but I'll show in a couple slides, really a lot is actually viruses. And this is really when you start to get kind of your lower airways. So you have the shortness of breath. You can certainly have other systemic complaints with pneumonia. And then pharyngitis, where we have our sore throat. So still more viruses for pharyngitis, but of course, strep pharyngitis or group A strep, where you start to have that kind of white exudates and stuff. That is, of course, bacterial. It does need antibiotics. Next slide. So this is a CDC where they looked at kind of the trends of antibiotic prescribing in across the board from upper respiratory, acute respiratory infections, and all antibiotics. You can see that from this period of 93 to 94, there is a decrease to 2007 to 2008 with total antibiotic prescribing for upper respiratory infections. And you can see here, especially for like otitis media went down, pharyngitis a little bit down, bronchitis did, sinusitis seems like maybe actually we're starting to prescribe more antibiotics for sinusitis. But you can see overall the trends were that we're making improvements in prescribing less antibiotics for these mostly viral infections. It is prescribing of antibiotics is highest in the extremes of age. So the very young and the very old, over 65, those are the two sides where they tend to get the most antibiotics prescribed for upper respiratory infections. Next slide. And then, so this is just kind of, I think crazy. So this is about 20 years ago where they did this survey of households. And so they kind of queried these people to determine how many upper respiratory infections are they having a year, how many common colds or pharyngitis, bronchitis. And then also, were you not able to work? Did you have to go to a doctor visit? Did you have to, take these over-the-counter meds, or did you take antibiotics? And they ended up kind of looking at the total economic burden of what those upper respiratory infections amounted to, and it was vast. I mean, because of all the impacts that's having on lost productivity, in addition to all the visits and healthcare kind of connections, it actually amounted to $40 billion every year that were just spent on upper respiratory infections. And this is actually 20 years ago. So that was in 2001 US dollars. So actually it's markedly higher. And actually just for over-the-counter cough and cold meds, it was $2 billion spent. So when this amounts to kind of compare to some of our other conditions that we treat, and this was 2001, you can see that actually upper respiratory viral infections cost more than COPD. They cost more than heart failure. They cost more than asthma, migraines, all these, and even was pretty equivalent, pretty on par with hypertension, and not that far below stroke, actually. So these things, although they are normally thought to be mild, they really do contribute a significant burden to society. Next slide. So, so over 500,000 or 500 million episodes of colds every year. So about 20% of those are actually associated with a doctor's visit or a clinic visit or an ER visit. And around 8% of total antibiotics come from upper respiratory infections. So this is amounting to a lot of antibiotics for what really mostly you can see on the right side is viruses. So when we talk about like the common cold, it's mostly going to be like rhinovirus, some coronaviruses. This was pre-COVID, but so the non-coronavirus, the non-COVID coronaviruses, flu viruses, respiratory syncytial virus or RSV, parainfluenza, and you can see some less common there. But really, and the bulk of them, are viruses for these. Next slide. However, so that was common cold. This is actually a longitudinal study where they looked at people that got admitted with community-acquired pneumonia. And so they really aggressively tried to diagnose what the pathogen was in these people. And you can see here, the orange, they identified, this was over the course of, I believe, 3 years worth of pneumonias nationally, a national sample where they looked at all claims data. And then they kind of did some retrospective to try and get these pathogens So single pathogens, so you can even see, although these were pneumonias and people were hospitalized with pneumonia, really the number one cause is rhinovirus, and followed by flu. And then you can see finally the third down right here is strep pneumo. So we finally get to some bacterial infections, but then it's followed by metapneumovirus, RSV, so virus. We finally get to another bacteria with mycoplasma and staph. But yeah, really, what we think of pneumonias, certainly probably a lot of these really too are viruses. And so what it amounted to, the total kind of aggregate, was that a bacterial pathogen was identified in only 11%. There were bacterial viral co-pathogens in 3%, but the bulk, actually the majority, were viruses. Of course, we don't always diagnose these, so no pathogens was detected in 60% also. So next slide. So this is a example of some community-acquired pneumonia guidelines. These are based off the kind of IDSA guidelines. So just an example, if you don't have any facility guidelines, this would kind of be a pretty good example. Gives you the preferred treatment with if there's penicillin or alternative treatments needed, and then the duration. And so we'll talk about the durations. I have down on this kind of example guidelines 5 days. And certainly you can adapt it to your facility guidelines, however you kind of choose. But 5 days really, we'll go over here in the subsequent slides, does seem to be pretty effective in treating community-acquired pneumonia. Next slide. So this is one of the studies. I'm certainly not going to talk about all of them. This is one study where they looked at adults that had community-acquired pneumonia, and they treated these people for either 3 days of antibiotics or 8 days of antibiotics. And you can see the cure at 10 days was actually equivalent for both those durations, 93% in the 3-day versus 88% in the 8-day course, but sustained. So they looked at up to a month, and a similar rates of cure between those short duration and the longer duration. But as you can imagine, half the amount of adverse events with those shorter courses. But and so this is one example. I'll have another slide about and kind of some other studies with some citations. But what in real world practice, so this was kind of on the right side of your screen. This was an example from where they looked at the VA, and they compared people that were coming in or hospitalized or going to the ED, and seeing how many days that they're getting antibiotic. And you can see that 93% of them are not in accordance with guidelines. So this is really, like, I would say, an upfront kind of low-hanging fruit, is to kind of get your facility guidelines and disseminate these guidelines and encourage, that we're getting our durations as only to the point where we need cure. Next slide. So this is kind of the mantra of shorter is better. So this is for pneumonias. There's been 14 randomized controlled trials, so where they look at these durations of either 3 to 5 days compared to 5 to 14 days. And that shorter 3 to 5 days is equivalent in cure to the longer duration. There's, I think it might be in one of those citations, but there's been some Cochrane analysis where they look at also long-term outcomes. So they make sure that these people are not getting readmitted with pneumonias, or they're not having, they're not going back for antibiotics to a clinic visit, or have, mortality. And there also is no difference in those longer-term outcomes for the short duration versus long durations. Next slide. So this is why, so for ACP, they put out this clinical guidelines best practice, and there's several other shorter durations, but I just did the respiratory best practice advice that they had, and you can see here that they put out this clinical guideline suggesting that we limit antibiotics for pneumonia, community-acquired pneumonia, to 5 days, and then for COPD, for acute bronchitis, or with COPD acute COPD exacerbation, to 4 days. Next slide. So moving into some of the, so that's just kind of the background, moving into some of the kind of interventions that we can think about doing. And this is based on it, once we have those kind of guidelines or like an algorithm. This is a group that ended up doing this upper respiratory management protocol. I know it's kind of blurry, but you can look up the citation there. I think it is kind of blurry in their article, but you
It
can see,
totally is, Kelly. I looked it up.
yeah, yeah. But you could see they kind of had acute bronchitis, common cold, acute pharyngitis, and then rhinosinusitis. And they gave this kind of just treatment algorithm and next steps, and whether antibiotics were indicated, not antibiotics indicated. And they basically just posted these around places where they laminated them, put them in work areas. They put out educational emails detailing kind of just simply this kind of guideline and algorithm. And what they looked at that over the course of a year, it actually was associated with a 10% decrease in antibiotics for all comers, for all the upper respiratory infections, especially nasopharyngitis, so our sinusitis and or not our sinusitis, our rhinitis and our pharyngitis. You can see that decreased 14%. So actually decreased to like 0%. And then acute bronchitis reduced 4%. Next slide. So those are, so that was simply just kind of disseminating the guidelines. Next, we were going to go over some of the diagnostics. And so rapid diagnostics, so these things like rapid, point of care, the PCR testing, certainly they have the potential, we hypothesize, to reduce unnecessary antibiotics. So if we diagnose, RSV, we're not going to prescribe antibiotics. And if we diagnose flu, then we improve our antiviral prescribing. There also is the hypothesis that it could limit unnecessary imaging and potentially shorten hospital or ED lengths of stay. And of course, optimize our infection control practices. But one kind of caveat for these is, they can be quite costly. So some of the multiplex ones, I've heard they even like the RVP can even be up to like $800, $1,000. And also we can be associated with some overdiagnosis. So we might have prolonged shedding of some viruses, and it might go on for months and months, and we don't know what that means really, Next slide. So this is out of the CDC, and they kind of, the CDC and the IDSA, and they kind of gave this a really good, interesting article on these upper respiratory kind of rapid diagnostics, and go through what are kind of the best practices for having these, the PCRs versus the antigen. So the first question they talk about is to test or not to test. And so not everyone needs tested for RSV or respiratory virus. Think about if it's going to change management. Think about the underlying population that you're serving. So is this a population that it would impact their treatment? Could they get, if we're during flu season, could they get Tamiflu? Or is this a population that's immunocompromised? Or is this a population that is anticipated to have worse outcomes? Versus is this a 19, 20-year-old that has a stuffy throat? Are we going to really need to get, a viral panel on that person? So the American Society of Clinical Pathology, they recommend against actually these broad respiratory viral PCR panels. So those RVPs, so broad use of them, they recommend against that, to really instead focus on the single rapid molecular test. So the rapid, the flu PCR or the RSV PCR or the COVID PCR, instead of using that entire combo multiplex PCR. So generally speaking though, so moving on to question 2, I decided to test what kind of test is best. So the IDSA and the CDC both favor using molecular tests, so PCR testing, instead of the antigen testing. And again, as I kind of alluded to, the multiplex, so it's certainly appropriate if you initially had the negative, flu, RSV, COVID, but you still are very suspicious for a viral, and this is going to change management. This is immunocompromised person or a person that has severe COPD is at risk. Moving on to that, to kind of understand, is this, what this is. And so also in the context of some immunocompromised people, it can affect, they can have prolonged shedding and might have infection control impacts also. So those are just kind of a little table about the, there's a whole, many types of molecular testing. The rapid molecular test with a turnaround time of, as little as 15 minutes. So next slide. So the question number 3 from this really great article is, what's the significance of bacterial DNA? So you also might detect with these PCRs, you might detect some bacterial DNA that might not have any actual clinical significance. So that goes back to question number 1, should I even order this? Is it going to impact treatment? Sometimes these semi-quantitative PCRs, so they can actually give like a volume, or they can give you an estimation of a quantity of how much is there, can be helpful in kind of delineating that. But there's also just this general question of and concern about whether we might be over diagnosing things with these PCRs. So this is a Cochrane review where they looked at 3 trials of these rapid viral diagnostics, because again, we think like, okay, well, we're going to diagnose a virus. We think we're not going to prescribe antibiotics, so that's what people aren't going to do. But indeed, these diagnostics were not associated with reduction in antibiotic prescribing. So kind of counterintuitive, but that's pretty consistently found that it doesn't seem like it does dramatically reduce the antibiotic prescribing. There wasn't a difference in the repeat visit, so people still have symptoms, they still came back. Next slide. Yeah, so this is an example where they actually was in urgent care clinics, and so they did a audit and feedback, and so they had clinicians, they educated the patients, they educated the clinicians, and then what they did is they provided feedback to these individual clinicians, comparing to their peers, but they had a local champion. So they had within the facility someone that really encouraged this, shared this material. They shared the I think it was quarterly feedback, but they presented this also to leadership in quality meetings. They actually had the medical directors that reviewed it, and they kind of gave some specific feedback. So this was really, really interesting, where they kind of did a lot of work around audit and feedback, just around the acute respiratory infections and antibiotics. Over, I think it was six months or a year, they found significant, well, actually it was longitudinal. So they continued this for, I think, 4 or 5 years. And you can find that, you can see by the graphs, the reduction in the antibiotic prescribing overall over this 4 or 5 year period. They had a 22% reduction in antibiotics. But conversely, where we think that there is maybe some reduction patient satisfaction if people come and they have the expectation to get antibiotic, but indeed that's not what they found. Over the long term, they actually found 6% increase in patient satisfaction by, probably the clinicians were, learning how to communicate better to the patients for, things to treat their infections with, or supportive care, we should say. Next slide. So another one where they use peers, basically these kind of people in the facility to encourage, like, be these champions. These peers were able to provide vignettes, or like case kind of, they would do cases, kind of go over case scenarios and stuff. And then they would report these these reports every quarterly, every 2 to 3 months throughout the acute respiratory season. So just throughout the kind of fall and winter season. And you can see here what happened. They did this, this was in an ED and VA sites. There might be some background. Someone might be off on mute, actually. But anyway, so they compared this to where they had the peers and where they were providing this feedback to where they weren't providing any, so the control site, so they were in the ED or the VA, so they weren't doing any of this peer support. And you can see the group that actually did the intervention, the significant reduction, the amount of prescribing that happened, because we want to be on par with who we work with. We don't want to be the outliers that are prescribing unnecessarily. So what they found is there's a 22% reduction in antibiotics for bronchitis, and 7% almost 8% reduction in sinusitis. And so they almost doubled the appropriateness of antibiotic prescribing from those ED and outpatients at the VA. Next slide. Next slide. Perfect. So this is, so I was trying to look around for some templates for kind of download. And this is the Nebraska's, the ASAP website, where many of you are familiar with. They have tons of resources. This was actually long-term care specific, and it was actually a kind of a sample peer comparison report. And then you can see kind of what they had, actually a couple examples on there that you could download and have a template. One was for community-acquired pneumonia, and they had I believe some others or one other one for upper respiratory infection. And it just, it's, provides a nice graph, provides a nice template. So this is something that you could incorporate into your facility. You could kind of compare different things. You could compare antibiotics for, say, pharyngitis. You could look at pneumonia for guideline adherence, type of antibiotic or duration. There's really so many different things that you could think about, kind of looking and kind of providing some feedback and making sure that your facility and your clinicians really are prescribing the best that we can for our patients. Next slide. Yeah, perfect. So this is, this is another example of like nudging, or these commitment posters. And so you can see here one of our facilities in Kansas, where they you kind of put it in a public facing area, but simply put, I mean, it seems so simple to put just like a poster like this up, but actually there's been several trials where they looked at clinics, actually. So two separate randomized trials where they looked at these putting these posters up versus putting nothing up, and simply putting that up and having that kind of accountability right in front of you every time that's right in front of you, you're like, you're about to hit send for your antibiotic, actually was associated with a 20% reduction in inappropriate antibiotics. So there is the link for the English poster, and then also the Spanish poster, which these are Kansas specific. And so certainly you can email KHC used to, you could email them, and they can also put like your logo, your facility logo on it stuff too, if you want. So something easy, really easy to do. And this is, these are some really fun posters that we update occasionally. Next slide. So moving into the communication training, so especially in your guys' setting, in the long-term settings, the nurse clinician communications are so important. Really, our nurses are the frontline clinicians that are taking care of these residents, and they're the ones that are communicating the change in status, or symptoms, or obviously talking to the patients and their families, and counseling them also. So this was an intervention where they did online education for these nurses for long-term care. It wasn't just an upper respiratory module. They had 5 modules. One was urinary tract infection, asymptomatic bacteria. I think there was a skin, soft tissue, and then of course the pneumonias and bronchitis and such. And then they also did kind of a infection control module also. These were 30 minutes and they were really interactive. Next slide. And so what they found after these 30-minute, 5 modules. So they did pre and post, knowledge, and so that did significantly improve for each of those 5 domains that they had the conditions on. But really importantly, what it also showed is that the nursing staff actually had an awareness, and they reported a greater appreciation that their role as the antibiotic stewards are key in these facilities. So they really appreciated how much they can affect the antibiotic prescribing for the residents. And then they just, as I mentioned, they had increased knowledge of the assessing baseline status and communication to how to communicate to the residents and to the families, and then how to do that also to the clinicians. Next slide. There's this technique, so specific to really not specific to upper respiratory infections, to a lot of infections. It's this negative versus positive treatment. So we would, if you, someone comes in and they are saying they're having a cough, and a sore throat, and I would say this infection is viral, so antibiotics won't help. So you're saying a negative. Basically, you're saying something isn't there. That's a negative kind of treatment recommendation. So that's what we do a lot. We tell people that we don't think that they have this. We don't need to get an X-ray, or we do need to. But it there also is the converse is the positive treatment recommendation. So it would be, I don't think that you have this, or I don't think that you have a pneumonia. I think that you have a virus. And then you follow that up with a positive treatment recommendation. So you give the next step. So you say, drink hot tea with a teaspoon of honey, or you say, if they're having shortness of breath, with their bronchitis, use an extra pillow at night to reduce that drainage and resulting cough. Or here's these recommendations of these lozenges that help, or whatever you're positive, you're giving them steps to do. So when combined, having those negative followed by those positive treatments, that really resulted with the lowest amount of unwarranted, unnecessary antibiotic prescribing. And also the highest association with satisfaction with that visit, with the quality of care. Next slide. So these negative, you don't have this is what you can do for what you have. So that kind of negative positive, that actually resulted in, and this was across like 2 years. So it was a long-term study that they looked at. But that negative followed by positive resulted in 85% reductions in antibiotics with that kind of negative positive kind of trend. When they looked at, so they did it was a controlled trial. So then they flipped them, and they did the other group, they only did positive. So they would only give recommendations for what to do, what to take for these types of viral or whatever bronchitis. And so although that did reduce antibiotics, it wasn't nearly as much as saying that negative and that positive. And interestingly, if they only said the negative, so they only said you don't have this, and that wasn't followed up with anything to recommend, that wasn't associated with any reduction in antibiotics. So that's really the key, is like giving them something to do. So we have that action bias that we talked about a couple sessions ago. So we want to tell people, we have this tendency to want to do something. And this is really, more helpful in figuring out kind of how people can do the next steps, so that they know when to call back. But really importantly, people just want to have some reassurance, and they want to know what they can do to get over their symptoms. They looked at this over the course of a year, and they actually found that, not just was it associated with reduced antibiotics, but actually it was reduced in unnecessary tests like CRP after a year, and really over the next year, almost 30% reduction in antibiotic prescribing. Next slide. So these are the nudging, kind of how you can leverage your laboratory that you work with. So we can put also things in our reports. So we get a sputum culture or any result, but really since this is upper respiratory and pneumonias. So in the sputum culture result, you could put a message such as, commensal respiratory flora or normal respiratory flora, but you can make that even stronger by you can specifying what's not there. So when, and subsequent slide I'll show, but by putting an extra comment in there saying that this wasn't there, like Staph aureus wasn't there, Pseudomonas wasn't there, it actually results in reduce, so we de-escalate off those unnecessary antibiotics. Next slide. So this is a couple studies where they did these nudges for sputum cultures and added extra comments about like, this is not there, this is normal flora. And you can see how significantly that was associated with reducing or de-escalating off of those antibiotics. Especially the one where they put that there was no Staph aureus or there was no Pseudomonas. Those really reduce those, like, the anti-MRSA and anti-Pseudomonal antibiotics significantly. And then there was another group with McBride and colleagues where they looked at the sustained effects, so 2-year period. And they found that indeed, really it does over the long term result in significant reductions in those antibiotics. Next slide. So this might be towards the end of the interventions before we get to the vaccinations, but this is delayed prescribing. And so delayed prescribing is where, we tell them that again, negative comment, don't think that you have this, here's what you can do. Here is what you can call me back, or you can call back if symptoms worsen. But the delayed prescribing is where then you provide that prescription, you provide that antibiotic, but you tell them either don't fill it for these many days or don't fill it until you have these symptoms. So there was 2 types of delayed prescribing where they looked at for a couple of these studies. One was a patient-led delayed prescribing. So they gave that visit, or they gave at that time the antibiotic, but said, don't fill it till you have these symptoms for these many days or these specific symptoms. And then there was a post-visit one. So after the visit already happened. But then they said, call me back on day 4 or 5, whatever, if you're still having symptoms, and then I'll prescribe it. So what they found is that those patient-led ones, so giving them that instructions, don't fill this until this many days, you do have this, you have this kind of comfort, because that's really what people want, is they want to make sure that they get worried that they're having symptoms so long that it's developing into bacterial. So that patient-led really was what resulted in the most reduction of antibiotics. And there wasn't importantly, no difference in patient satisfaction, no difference in the duration of symptoms or the severity of symptoms for that delayed prescribing approach. Next slide. So this is a big meta-analysis where they looked at delayed prescribing, and indeed it confirms that there's a greater odds when you use this kind of approach that people will not receive those antibiotics. And this group where they looked at this meta-analysis, and these were randomized trials, so they didn't, this meta-analysis didn't find any difference if they were given them at the visit or they called back after so many days for this particular one. Also confirmed there was no difference in satisfaction, and there was also importantly, there was no difference in return visits. So keep coming back, I'm still having these symptoms. That also didn't happen. Next slide. So this is kind of an example. We need to get it up on our website, because we've been talking about it for so long. We have all these resources, but this is kind of that example of that delayed prescribing or this communication kind of where you give these positive kind of suggestions. So you can see all these, you can check mark what they have off. They have upper respiratory infection, they have viral pharyngitis or whatever. It tells you how many days to call back if you have symptoms. And then, but really importantly, what people want is symptom relief. And so you can kind of check mark all these things off that you think would help them. And it will, and also I think what's helpful for this too is where it gives the duration of symptoms that you're anticipated to have it. So, bronchitis, you can have symptoms for weeks and weeks, unfortunately. And so that just is a reminder that this is the normal course of events. It's nothing that should be concerned unless you have this specific symptoms kind of at the bottom there. Next slide. And then, so patient public education. So sometimes we overlook this, but really this also is so key in making sure that residents and patients are aware and, you know, there is ability of passive education. So we post things like these or put information around, but they don't necessarily reviewing it. Not as much impact, of course, as you can imagine, as when we do this active strategy. So we're really, you know, conversing, talking about these things with them. This is another download for a lot of these really nice Kansas. It's a social media toolkit, so it's lots of examples for different kind of comments and that you can have with with people, and you could also post these and stuff, especially for Antibiotic Awareness Week is when these come out. Kind of we've done a few years of these different kind of social media texts and stuff. Next slide. Finally, I think this actually is the last before I lied. I didn't go on to immunizations yet. So this is on the horizon. And so this is something we tracked at KDHE. So this is antibiotic prescribing for acute respiratory infections. So we looked at this time period from 2019 to 2022 and looked at all these 24 different ICD codes that you see here. So for instance, influenza A, viral pneumonia, acute bronchiolitis. So things that generally are most definitely not associated with antibiotics. So it's not like that wiggle room of, you know, COPD exacerbation where you could prescribe antibiotics. These are pretty much don't need antibiotics. And then we tracked it by total antibiotic use and mapped it. Next slide. And then we, this is coming out in the fall to do as like what we already talked about is peer comparison. So this is like really statewide comparison by counties, but also clinicians are going to be getting their individual quartile of how they compare to the rest of the their Kansas peers, because this really is one of the most impactful things that really does improve antibiotic prescribing. The letters are basically, we did vet these with several clinicians, physicians, to have the right kind of message framing also. Next slide. And you can see here, so this is the map of the different quartiles. From the darkest orange would be the highest prescribing for these upper respiratory infections, versus the light blue, the first quartile is the lowest antibiotics being associated with those 20 ICD codes for respiratory infections. So this is something that we're working on getting sent out to individual prescribers, and we are working on this, as Brenda really has been the primary person doing this. So kudos to her, Brenda. You've been working a lot on that. Next slide. So finally, I'm moving on to vaccines to wrap up the latter part of this. I think vaccines really are such an important part of stewardship and infection prevention. This was a study where they looked at a course of, I believe it's 4 flu seasons, and they did claims data also, and they linked it to how many antibiotic courses it was associated with, like conglomerate, and then they also looked at outpatient visits too. And so what they found that with the higher the amount of flu vaccination, that it actually was associated with a flu season could be reduced with 28% reduction in duration of illness, duration of antibiotics for those febrile illnesses. So this is all comers. So, and they looked at different years, and different years where some were lower rates of vaccination, some were higher. But what it ultimately found is there was a significant reduction in the amount of antibiotics for febrile illnesses when the higher rates of flu vaccination happened those years. And especially for kids, there was about a third decrease in antibiotics for children. That was actually a separate meta-analysis that they looked at that. Next slide. And what especially our program looks a lot at is antibiotic resistance. And so we think like, how can vaccines prevent antibiotic resistance? This is an example of, you see the pneumococcal vaccine, the conjugate vaccine that was first introduced into the year 2000. And you can see for the age groups, the under 5 and the over 65, you can see what happened in that subsequent decade after that that Prevnar 7 was introduced. Such low rates, low decrease in those rates of those strains in that vaccine. Next slide. And here's another, in the subsequent slide, I'll show you in particular some of the reductions in those pneumococcal ones with the Prevnar. But this is another example of how the vaccine, so this is an example of the Haemophilus vaccination. So when it was introduced in 87, and there was the rates around that time was starting to be for ampicillin, around a third were resistant of that Haemophilus to ampicillin, and around 20% resistant to Bactrim. The vaccine was introduced, the rates of Haemophilus went so much lower, so much less pressure, so much less antibiotics being prescribed. You can see what happened in the subsequent decade, that the ampicillin resistance of these Haemophilus started to decrease. So not as many infections, not as many antibiotics, and not as much resistant is what the long-term impact is from that. Next slide. So, so strep pneumo, so this is Kansas data from 06 to 2020, and you can see these are invasive pneumococcal incidences. So pneumonias with like bacteremias, or for instance, another invasive would be like meningitis. So you can see here, the rates really are going up in Kansas pretty steadily. So we definitely have we should be making a big effort to vaccinate our population. Next slide. And then the 2020 data, you can see that it wasn't, it's still preliminary because of the COVID, but you can see here from this one too, these are pneumococcal cases from that same period where you can see the trend is moving upwards. Next slide. So there is the capsule, so the conjugated pneumococcal versus that polysaccharide, so the protein one versus the sugar one. So the conjugated, which is kind of linked to that protein carrier, so it just really results in a much stronger and longer lasting B cell response. So you give that conjugated vaccine, and we'll talk about which ones those are, and you don't have to vaccinate them as frequently. Indeed, perhaps with this most recent one, it's not recommended necessarily that they need even another vaccine, but really it results in stronger response too, versus the older ones of the sugar ones. So that would be stuff like the Pneumovax was our older polysaccharide pneumococcal vaccinations. So in 2021, there was 2 new pneumococcal vaccinations approved. So there was the PCV15. So it has protection for 15 pneumococcal serotypes. And then same year was the PCV20. That was Pfizer. The 15 was Merck. The 20 is called Prevnar 20 versus the PCV15 was called Vaxneuvance. And so you might, the old vaccine, the old one, which was the 13, protected against 13 serotypes, is Prevnar 13. So just kind of an update, more serotypes basically that they were able to fit in these vaccines. Next slide. So you can see here the differences in the serotypes. And really what the focus is, because you want to make sure that you're preventing the serotypes that are the most likely to cause severe disease, most likely to cause pneumonias, to cause associated meningitis. And so you can see here how there was an expansion in the amount of the Prevnar 20 compared to the Prevnar 30. You're getting more of these serotypes that are causing a lot of these more severe diseases. Next slide. And then interestingly, we have some types of the strep pneumo that tend to be more resistant than others. So they tend to have more levaquin resistance, or they might be more clindamycin resistant. And so there are certain strains, the ones that I circled here in red, those are the ones that tend to be more resistant. And you can see indeed the Prevnar 20 and also the Vax, Nuvance 15, just really doesn't roll off the tongue very well. You can see that those really are containing those kind of serotypes to protect against some of the more resistant strains too. So hopefully, you know, long term is hope to not just reduce the incidence, but reduce the associated resistance that's happening from having these infections also. Next slide. So last year, the ACIP made the recommendations. And so it used to be so confusing with like for this population, you had diabetes, you could give the Pneumovax, and then you had to wait, 2 months for if they're immunocompromised to give Prevnar. If you gave Prevnar, you'd have to wait a year to give. It was very confusing. So now it's much simpler, much simpler. You can just see it's across the board. The recommendation is you give the pneumococcus, the conjugate one. So the Prevnar 20, you just give a single dose. That's it. There's no boosters. There's no Pneumovax following that. Because the 15 one, the Vax, Nuvance, whatever, 15 has less serotypes, so you're missing out on protection. You can have the option of doing that 15 followed by that sugar one, that polysaccharide one, the Pneumovax, after 1 year. So I think just generally though, in my mind, I mean, mostly, the 20 is where we've went to vaccinate, and it just really has simplified the process. Next slide. And those are for everyone over 50, everyone from 19 to 64 with any comorbidity. And then they do kind of, because we'll see some people, they have had, they're maybe in the middle of, they had a Pneumovax. What do you do for those people? So they had their polysaccharide one. So the recommendation is, because you have such much better with the conjugate vaccine, this newer vaccine, you give the Prevnar 20 because it'll just have so much better recommendations. And then so you'll have also a lot of people that did get like that the older Prevnar one, the one that had the 13 strains, and they had the Pneumovax. For both those people, because they had pretty good protection with the 13 plus the Pneumovax, it's kind of optional. You don't have to give them the Prevnar 20, but if they're high risk, they have people with like really bad lung disease, they're immunocompromised, then I still do give that population, because you're still getting more protection from that expanded amount of serotypes. Next slide. And so this is just kind of a graphic. We kind of forget how impactful these vaccines are, but I mean, these are preventing 16,000 meningitis cases since it's been introduced, 250,000 pneumonias, 750,000 hospitalizations, 3,000 deaths. Think of all these antibiotics that are being prevented by preventing these ear infections or these pneumonias. So really a lot of antibiotics can be saved by vaccinating people too. Next slide. So RSV is I know I only have 8 minutes left, so I was going to go over the new RSV vaccine maybe you've heard about. So this is from the RSV net. So you can see here the groups that's highest risk of severe outcomes or hospitalizations with RSV. So especially those over 60, especially over 65 years of age. Next slide. So there's 2 vaccines, and they both got FDA approved in May, and they're both for over 60 years old, 60 or over. So the SmithKline one is called Arexvy, and then the Pfizer one is called Abrysvio. Basically, the GSK one, the Arexvy, is like a recombinant fusion antigen, and then the Abrysvio one is protects against RSV A and B. And it also is like, it kind of prevents that virus being able to attach to cells. So it's a pre-fusion kind of vaccine. So these are the efficacy. This is, they kind of had some different, this 2 studies had some different definitions of like lower respiratory infection. So that might account for a little bit of the difference in the vaccine efficacy. But you can see really overall pretty effective in reducing disease across the board. So having lower respiratory infection with 2 or more symptoms. So really we're not getting people that are having much symptoms at all. So 67% for the Pfizer one, the Abrysvio, or the GSK one, the RexV was 83% overall. And then you can see the breakdown. It holds up to the even over the 70s and the 80-year-olds too. High risk people, so people with those lung disease, cancer, immunosuppressed, COPD, also you can see very effective for those populations also. So pretty similar to the vaccine efficacy is similar to those high risk population that really need these. Next slide. And then, so importantly, hospitalization. So, I mean, we could get like a little cold from RSV, but we we especially want to prevent severe disease. We want to prevent that hospitalization. And so you can see here how effective it was. So people were more likely to have, even though it was effective in preventing all infections, so 67 or 80%. But really, when you get to talking about severe disease, having to go to the hospital, 85 or 88%. So really quite effective in reducing these. Keep in mind, this is over the course of 1 year. So they are looking at year 2. And I didn't really get into that data because I can't remember which was Pfizer or GSK, but they did publish that data, and it does hold up. It reduces a little bit. But that is pretty dramatic effects, especially for this population that really needs it. And then also outpatient visits. So not just getting a really severe one, getting hospitalized, but going to needing to go to a clinic visit. And you can see that those two were quite a bit of reduction in preventing those. Next slide. And then side effects. So fatigue, headache, they're pretty on par with placebo. Some of these are a little bit higher, and I gave the citations there if you are interested in looking those up. But really fatigue and injection site pain are the main side effects, a little bit of muscle aches. And it's one dose at this point, just one dose, not having like an annual booster or anything like that. And because they're so hard to pronounce, there's a link if you want to figure out how we can try and pronounce some of these, new names of these vaccines they're producing. Next slide. And I see Carrie Bierman asked the question, do you know if the RSV vaccinations will be covered by Medicare and Medicaid, especially for long-term care residents? So because the ACIP recommended them over 60, that's my understanding is that they should be covered by Medicare and Medicaid. And we do not have it yet. I believe we're supposed to have it by October, I think. Last one I was going to talk about is pertussis, because this is called the 100-day cough. I've seen some people that have this, and it's just such an annoying cough. You can see here this kid was coughing so much he kind of got this broken blood vessels here, but I have seen some people, it's just such an annoying cough. They cough and cough for so long. And you can see here in 2012 we had a lot of cases. And so we don't see as many lately, but I always think I always try to vaccinate people against pertussis whenever possible. Next slide. So this is the pertussis vaccine is the Tdap one. So that's the where you also have the tetanus and the diphtheria. And so you could say, if people need a tetanus, they come in the ER, they got like a puncture and they need their tetanus. I find no reason to just give them the TD, the tetanus one. Really, I think we should be giving them the Tdap pretty much across the board, because the pertussis whooping cough is so much more common than tetanus. So I think it's an opportunity to just get them their Tdap. And also don't forget that for people that if there's a newborn, household contacts, including grandparents, care providers, they should be updated with their Tdap or their pertussis vaccination, because these young children can have such severe outcomes with pertussis. Next slide. Next slide. So these are just some kind of pearls and stuff to think about how we can improve our vaccination. We can think about it being provider-based or facility-based, certainly working with our occupational health to offer flexible vaccinations for both our workers and then also our residents. You can also include it in like a quality of care metric for whichever vaccination you kind of chose. You could have standing orders. These definitely increase the amount of vaccinations that happen. So on admit, on transfer, rather than requiring like each signature. You could also just kind of especially target the certain people by diagnosis or comorbidity or age. And sometimes there's a lot of studies that look in like how to pull this into the EMR and by doing this too. So really doing these kind of practice-based things, these kind of systematic ways, it's really been found to be the most effective in really increasing our uptake of vaccination. But there's just kind of a host of different kind of ideas how we can improve our vaccinations. Next slide. Any questions?
I think you answered the one that was in the chat already. There is a comment here from Mary. Medicare will not reimburse a clinic for Tdap unless it has a Medicare D license, which most don't, only pharmacies. So in an office, Medicare will only pay for the TD and only for a skin injury. The RSV vaccines are also covered by Medicare D, so don't know yet if they will reimburse a clinic for these.
Those. Yeah, and that is for some vaccinations, like also the Shingrix too. So it's completely silly. So you just tell them to get their vaccination at the pharmacy instead. So yeah, that's definitely a good point, Mary, to keep in point, is to keep that in mind when you recommend these.
Any other questions out there? Well, I am not seeing any. Thank you again for another great presentation. And also thank you everyone for joining us. Upon ending the webinar, the evaluation should appear if it does work as planned. So please do take a couple minutes just to provide your feedback. And then next month's webinar will be on September 21st, also at 1:30, and it will be directed on initiatives towards diarrheal illness and early detection of facility outbreaks. So it'll be another great topic. I am not seeing anything else in the chat. Well, maybe there is one. Oh,
Thanks,
just
Nadine.
a thanks, Kelly. So we will go ahead and end today's webinar, and thanks again, everyone.